respected seniors and dear friends. Today we are going to talk about a very routine, very common problem, that is PDPH, post-dural puncture headache. We are using spinal anesthesia in our day-to-day practice, and those who are practicing spinal anesthesia definitely severe headache in the post-operative period, and it was associated, but headache was present till next day. After this incident, Bayer and his assistant Dr. August Hildebrandt took spinal themselves, and after spinal they felt headache almost for 9 days. So they felt very severe headache, and they described in their literature that symptoms vanished when I lay down flat but returned when I stood up, and I was forced to take bed and remained there for 9 days because of all manifestation recurred as soon as I got up. So he described it very well that it was associated with posture. In recommend or sitting posture it came, and in supine position it was relieved. So with first and second spinal only PDPH was mentioned, but initially incidence was very high because needle size was high, needle size was very thick. The incidence noted was 50%. In 50% of the patient were feeling spinal headache, but in 1950s it came down to 10%, and recently it is roughly 1% only, but it is highest in obstetric patient. It is 1.5 to 2% in obstetric patient, even with spinal needle width 27 gauge. So incidence is still high, but we don't know exactly what is the pathophysiology. There are many myths and there are many controversies. No one knows exact pathophysiology. No one knows how it occurs. No one knows how we can prevent it. No one knows how we can treat it. There are many theories, but each and every theory has some problem. So we will discuss it one by one. So by definition, postural headache following intervention that disrupt meningeal integrity is called post-dural puncture headache, or PDPH. But if we think logically, PDPH terminology only is misguiding. Is it really post-dural puncture headache? It is actually meningeal puncture headache. When spinal needle pierces dura and meninges complex, then only CSF comes, and from there only CSF leaks. If you look at the electron microscopy of dura and meninges, dura is 400 micrometer thick, and meninges are 40 micrometer thick. Dura has crisscross many direction fibers, but if you look at the meninges, uh, it it has got tense fibers with a tight junction, and it prevents leaking of CSF. Dura is permeable, but meninges are not permeable. So healing of the meninges is more important than healing of dura to prevent the headache. So actually it is a meningeal puncture headache, but for years it is known as PDPH, and we will talk as a PDPH only. Recently, we did a survey for the anesthetists of Rajkot, and tried to see how frequent is the PDPH in their practice, and what measures they took to prevent it, and when it happens, how they treat it. So 70 anesthetists in the Rajkot took the survey, and most of them, roughly 85% of them, faces 0 to 10 post-dural puncture headache in a year. Some of them are getting 10 to 20 patient per year, and very few, they are, I will say, they are very honest, they face is more than 20 post-dural puncture headache in a year. So we asked them that what do they think, that what is the culprit for PDPH. Most of them believe that size of needle is very important. Some of them believe that type of needle and direction of needle is important. So everybody be- mo- believes that needle is important to prevent the post-dural puncture headache. But we will see in how important is needle and the size of the needle to prevent the PDPH. So first myth I will say, we believe that post-dural puncture is a benign, self-limited, and it is not bothersome to the patient. Is it really true? If you visit the patient and if you ask them, they will say it is a debilitating headache. They are unable to care for that baby, and it is worst headache of their life. So it is very stressful, and to especially to mother when they get after CS or painless labor. So it is first myth, that it is benign, and that's why incidence of shoes are very common after in obstetric anesthesia. It is the second commonest cause of medical shoes in USA in obstetric anesthesia, that is PDPH. So we have to diagnose it, we have to treat it accordingly, we have to talk to the patient and treat the PDPH, because in India also the medical issues are more coming more and more, and if we are not vigilant, then there are chances we will get sometimes because of PDPH. So another myth is we believe that it is a short-term headache, but if you look at this chart, in most of patients, 75% of the patient, you are right, it is less than 1 week, but roughly in the 10 to 12% of the patient it lasts more than 6 weeks. And actually there are studies where they say is that it lasts for a year also, and it gets converted to chronic headache, and we need to treat it. So be careful, never neglect post-dural puncture headache, that it will go away within small time. Sometimes it becomes a chronic problem for a patient. So always treat it and always manage it. Third important myth: do this patient after giving spinal, whether we should advise patient bed rest or rest is bed. I mean, we need to advise them early mobilization. If we look at the different studies, we will say what is right and what is wrong. And second myth about prevention of headache is oral fluids and IV fluids. We advise them lots of oral fluids and IV fluids to prevent PDPH, and it is common myth. I was also believing that it helps. Lots of fluids and bed rest helps to prevent PDPH. And in our Rajkot survey, you can see most of our anesthetic colleague believe, 76% of them believe that bed rest is important. Lots of fluid, 88% believe it can prevent the headache. Only 4% believe that early mobilization is important. If we look at the literature, there is a big meta-analysis in 2002, and they realized that there is no good evidence from randomized trial to suggest that routine bed rest after dural puncture is beneficial. It is not helpful. The role of fluid supplementation in the prevention of post-dural puncture headache remain uncertain. In USA, they did study, and yes, they believe that bed rest is important. You should give intravenous and oral fluids. But when they did similar study in UK, they found that 75% of the anesthetists mobilize the patient early. They believe that early mobilization helps. There are no actually there is not concluding data that which is more helpful. They did again similar meta-analysis in 2006, and findings were similar, that neither bed rest nor IV fluids help to prevent headache. But I will say dehydration causes headache, and it aggravates PDPH. So if you don't give adequate fluids, it will cause dehydration, and again that will lead to aggravation of post-dural puncture headache. So it is important to give adequate fluids to prevent to prevent exaggeration of PDPH, but early mobilization or bed rest neither is proved. So you can mobilize the patient early, you can give him head up position. Don't worry if you are giving a spinal with 25 or 27 gauge needle or 23 gauge. Even with whatever type of needle, you can ask the patient to mobilize early. It will prevent deep venous thrombosis, and it won't increase the chances of PDPH. Another myth: size of the needle. We believe that size of the needle important. Earlier we were giving spinal with bigger size needle, and it was the cause of PDPH. Yes, it was true. With bigger size needle, it is definitely that there are higher chances of PDPH. But if you compare the needle like 23, 24, 25, 26, 27, or 32 or 29, there is not much difference. With change in the size from 23 to 32, incidence of PDPH is not very different. It is similar. I will say it is similar. So you can use either size of the needle. Another myth is type of needle. Whittaker and Whittaker and needle is a pencil point needle and Quincke needle, that is sharp cutting needle. So there are many studies which says that Whittaker or pencil point needle has less chances of mm, PDPH. Theory, actually theory is sharp needle causes a flap-like puncture in the dura, and it takes time to heal. But pencil point needle, it is a blunt tip needle, so it creates more it creates it damages more dural fibers. That's why there will be more inflammation and there will be more earlier healing. But these are all theories. No one knows what is there exactly. There is another theory where it says that with the Quincke type of needle, if you keep the bevel of the needle towards the skin, it will create a rent inside. So when you remove the needle, the rent will again get closed because of the pressure of CSF, and it will close earlier. But if you keep the bevel side away from the skin, then it will create a rent outside the dura. So it will keep leaking, and it create there are chances of headache more. But with but neither with Whittaker nor with Quincke there is much difference of PDPH. So here we did the study in the Rajkot group, and they said most of the anesthetists are using Quincke needles and they are happy with it. Most of the anesthetists in the Rajkot are using 25 gauge spinal needle. Some of them are using 27 gauge, and some of them are using 23 gauge spinal needle, but incidence is almost similar. So if you look at the literature, in 2017 they did a study, and author realized that the study um, uh, they found that there is moderate quality evidence of traumatic versus atraumatic needle, suggests that further research is likely to have an important impact on our confidence in the estimate effect. They didn't found much difference. Uh, in in a second study, they compare the size of the needle and traumatic and atraumatic, and they didn't found any significant difference in the incidence of PDPH with different type of needle and different size of the needle. So size of the needle and type of the needle doesn't matter much. Myth 5: direction of the needle. There was a study which said that if you keep the spinal needle bevel parallel, especially for Quincke needle, parallel to the long axis of the spine, it will separate the dural fiber. And if you keep perpendicular to it, it will cut the dural fiber. So chances of headache and more CSF leak is with perpendicular needle. But if you look at the dural structure, it is not like dural fibers are in the longitudinal direction, but they are arranged in the haphazard manner. They are crisscross in the crisscross manner. So a theory is faulty there only. So if you keep the bevel of the quinky needle perpendicular to the or parallel to the long axis of spine, it doesn't matter much. Treatment, there are lots of controversy in the treatment also. There are various treatment options are suggested. First is uh, we believe that lots of fluids help, but another thing we advise is head low position. Here you can see in the Rajkot, most of the anesthetists believe 92% believe that lots of fluids are important. Head low position, 69% believe, 63% are using caffeine, some of them are using denifilin, complamina retard. No one knows the mechanism, but in the group anesthetists it was discussed, and many anesthetists are using nowadays with good result. Epidural blood patch is not very commonly used in India. Some of them are using nerve blocks also. So everybody tries different things, but most of them believe that fluids and head low position helps. But it is actually my myth. Neither fluid nor head low helps. Actually, when you give head low or keep the patient in supine position, patient will have symptomatic pain relief. But with supine position, it won't treat the PDPH. For treating the PDPH all over the world, it is believed that epidural blood patch is most effective treatment, but it is not the treatment. Some of us all believe that it is the treatment, it gives 100% result, but it is not true. In most studies, 75% of the patient get pain relief with epidural blood patch. Remaining 25% remain um, yeah, um, uh, uh, remaining 25% don't get adequate pain relief even with blood patch. Various treatment options are tried, like if you give time, 59% of the patient will have pain relief in 4 days. 80% will have spontaneous resolution of symptom in 1 week. But 4% of the patient remain symptomatic up to 7 to 12 months. So to prevent this chronic pain, epidural blood patch is good. You can try whether another options like giving analgesic, avoid dehydration because it exaggerate. You can use methyls and things like caffeine, derifilin, or aminophyllin to treat. They helps by causing vasoconstriction, but it is not always helpful. Um, if you look at the pathophysiology of headache, there are two mechanisms. First is by um, because of low CSF pressure, there will be stretching of meningeal structure, and second theory is because of adenosine induced vasodilatation, there will be headache. So if you give caffeine, it will lead to central vasoconstriction, and it will help to reduce the symptom. But it is not 100% again. Whether there are various treatment options like sumatriptan, ergot alkaloids are tried. Some of them have given epidural saline also. They give 40 or 50 ml of epidural saline to treat the PDPH, but it is not as effective as epidural blood patch. When you are giving epidural blood patch, again timing of blood patch is important. If you give earlier in the first or second day after accidental dural puncture with epidural needle, symptomatic relief, it won't prevent it, But if you have but if you get the moderate to severe headache, you have to time the epidural bed patch after this symptom, 1 day after this symptom. So it is the ideal timing. Or you can give after 72 hours of the accidental dural puncture. So there are various studies. Some of them are using 72 hours after. Some of them are using after first symptom of headache. Some of them are taking 24 hours after moderate to severe headache. So there are various theory. There is no single theory. Volume of the blood, they have tried 10 to 30 ml, but ultimately they found that 20 ml of epidural blood patch is enough. When you inject the drug, you have to ask the patient for fullness in the back and some severe pain in the back or buttocks or cervical spine. When it happens, you have to stop pushing the blood. So that is the end point. But in our India, it is not used that commonly. If we look at the Indian data, why incidence is low with our patient? There are many reasons. Labor analgesia is less popular to Western countries. In our country, in labor analgesia, there are chances of accidental dural puncture with epidural needle, and in those cases, incidence of PDPH is 50 to 60% because dura is punctured with 16 or 18 gauge needle. Uh, uh, we don't do regular follow-up. Our follow-up is very poor. And third problem is tolerance of patient is high. Our patients don't complain much when and especially when they have baby, they, they are full of joy and they don't complain much. That is why I think incidence is lower in India. But for us, history and examination is very important. When patient or surgeon calls you that patient has headache, don't neglect it. Always visit the patient, take proper history, check. There are many reasons for the headache. Sometimes patient have preeclampsia, and because of hypertension patient is getting headache. Sometimes patient when you use air for checking the epidural space, it can cause pneumocephalus and it can cause headache. But this headache happens in first hour, within an hour or two. But usually PDPH happens after 24 hours most of the time. So history is important. You have to check whether it is bilateral headache or not. Patient has any history of headache. Sometimes patient is has having a migraine or some other chronic pain, chronic headache. So you have to ask for the history. You have to examine the patient properly and look for the signs of another sign symptom. Sometimes patient develops subarachnoid hemorrhage or subdural hemorrhage in the postoperative period. So never neglect the thing. Properly examine the patient, take proper history, then only advise the treatment. If you look at the data, 60 there are two studies and they found that post-operative headaches are because of many other causes. Here you can see in the first study they found that 75% of the patient has headache because of migraine, tension type of or cervicogenic or cluster type. In another study, they found that only 60% headache was because of PDPH. Rest of the headaches were because of another reasons like preeclampsia, eclampsia, tension type headaches, etc. So you have to take proper history. What is new in PDPH? Recently, uh, actually, greater occipital nerve block and spinopelvic ganglion blocks are practiced to prevent practice in chronic headaches. But here also they give good result. And recently, I heard about a study where they gave both greater occipital nerve block and spinopelvic ganglion block to treat the PDPH, and they had a good result. Spinopelvic ganglion block is very easy. You have to put a xylocaine soaked wick in the nasal cavity near deep inside, and it will block the spinopelvic ganglion. Uh, for greater occipital nerve block, you have to palpate occipital protuberance. and go medially to palpate the greater occipital artery and inject local anesthetic there is in the subcutaneous layer. So they are very easy blocks and you can give it. Again, complement retard, that is xanthine nicotinate, is discussed many a times in the group the anesthetics on Facebook, but no one knows what is the mechanism, but it helps. Many patients get relief. It is given 500 milligram TDS, and it is wonderful. I wish we can come with some study with complementary retard. So important points to remember: hydration is important, but it's not the treatment. It helps to prevent exaggeration of the symptom. Bed rest is no longer recommended after spinal. Treatment should be stepwise. Initially you have to ask the patient for adequate hydration, some good analgesic. You can try caffeine or complementary retard, and early epidural blood patch is not helpful so if required you can try it, you can give it to treat the PDPH. Smaller size of needle is good, but not always. Never neglect post-operative headache. At least visit the patient once. Take proper history to prevent some uh, catastrophe. Actually, I have also seen one patient who developed a headache after hysterectomy before 12-13 years. Patient developed headache. I advised him bed rest and lots of fluid, IV fluids. Patient got relieved of the symptom, but when patient was getting discharged from the hospital on the third day, patient developed convulsion, and when we went for CT scan, patient has SOL in the brain, which was the cause for the headache, and yeah, because of CT scan we can treat it. So this is all about PDPH and controversies. Thank you for patient hearing. Thank you very much.